Good afternoon, my dear friends. It's my honor to join today's online course. And today I'm going to talk about ultrasound diagnosis and the guided injection for cervical spine. And I'm going to focus on the pathology of the brachial plexus. So first, I would like to be grateful for my good friends who invited me to this great conference. And also, I would like to appreciate WeSonic to hold this online conference. And as you can see now, there are more than 700 attendees to join today's conference. And I think using internet, probably there will be more people to know how fantastic ultrasound is in guided injection and diagnosis. And if you are interested in my today's talk, you can refer to our publication. This article published in 2016. And in this article, we include lots of videos and pictures. So if you want to learn how to scan the nerve over the cervical region, you are welcome to download this article. And if you are familiar with the sonal anatomy of the cervical nerve, you are also welcome to retrieve this article, Ultrasound Guided Intervention of the cervical spine and the nerves. In this article, we are going to tell you how to inject the nerve in a safer way. And if you want to know how to scan the axial spine in a precise way, you are also welcome to download another article. This is a sonal anatomy of the spine, a comprehensive scanning protocol from cervical to sacral region. And then this is the article we recently published. It's a sonographic pulse for image of imaging the brachial plexus and its pathology. And this article is more suitable for advanced scanners. So in this article, we not only introduce how to scan the normal spine, we also tell you how to differentiate the normal ultrasound presentation from the pathological findings. And if you want to use ultrasound to scan the spine, it's very important to know the configuration of the bony structure of the cervical spine. And for C1, we also call it atlas. It does not have a spinous process, or its spinous process is rudimentary. And it has a very prominent transverse process. And for C2, its characteristic is its spinous process. Its spinous process is bifid, so you can recognize the C2 through recognizing the bifid spinous process. And for C7, its transverse process is different from others. It has a very prominent spinous process, so you can palpate the spinous process when you perform the physical examination. And for the transverse process, it does not have the anterior tubercle. It only has posterior tubercle. And for C3 and the C6 is what we call typical bony configuration of the cervical spine. So for typical bony configuration of the cervical spine, you are going to see the vertebral body, the transverse process, and there are two tubercle, anterior tubercle and the posterior tubercle. And posteriorly, you are going to see the articular pili and the facet joint, and then lamina and the spinous process. This is the typical presentation of the cervical spine. And another important thing is, if you want to use ultrasound for guided injection, it's very important to know which label you are scanning and which label you are targeting. And we know there are 7 cervical vertebrae, but there are 8 cervical nerve roots. So if you scan the nerve root cranial to see the C7 level, you are going to find the nerve root exits after it exits the intervertebral foramen. It's going to cross cranial to the corresponding level of the transverse process. For example, the C5 nerve root, after it exits the intervertebral foramen, its location will be cranial to C5 transverse process. But in contrary, if you are scanning, for example, L1 nerve root, you are going to find the L1 nerve root is actually caudal to the L1 transverse process. And when we do the injection, it's very important that we need to prevent not hitting important vascular structure. For example, at the cervical spine, which important structure we have to pay attention to? At the anterior part, we have to prevent not hitting the vertebral artery. And the vertebral artery is the branch of the subclavian artery, and it's going to enter foramen transversalis, usually at the C6 level. So it means at the C7 level, the vertebral artery is unprotected. And then there are also some artery like ascending cervical artery and the deep cervical artery. Both artery course very close to the facet column. So it means when you perform the medial branch block or when you perform the facet joint injection, you have to be careful about not hitting the ascending cervical artery and the deep cervical artery. And if you want to target, for example, the stellar ganglion. Stellar ganglion is located at anterior to the longest colli muscle. So there is artery very close to it. The artery is the inferior thyroid artery. And this is the brachial plexus. There are 5 nerve roots constitute brachial plexus, including C5, C6, C7, C8, and the T1. And the brachial plexus can be divided into 5 levels. The first level is the root, and the second level is the trunk. Third level is the division, and the fourth level is the cord. And then you are going to see the level of the peripheral nerve. So this is the illustration you can find in my paper. So in this paper, we can also see some small branches originating from the nerve root and the other part of the brachial plexus. So this is the root C5, C6, C7, C8, and T1. And at the root level, you are going to see 2 nerves. One is the dorsal-scapular nerve. The other is the long thoracic nerve. Dorsal-scapular nerve originates from the C5 nerve root, and the long thoracic nerve receives fiber from C5, C6, and the C7 nerve root. And at the level of the trunk, you are going to find the suprascapular nerve emerge from the superior trunk. And then you can find the superior trunk, middle trunk, and the inferior trunk. All of the 3 trunks give off the anterior and the posterior branch. So the anterior branch of the superior trunk and the anterior branch of middle trunk, the 2 nerves merge to become the lateral cord of the brachial plexus. And for the anterior branch of the inferior trunk is give off the middle cord. And for the 3 posterior branch from the 3 nerve trunk, the 3 posterior branch merge to become the posterior cord of the brachial plexus. So at the cord level, you can find the lateral cord give off the musculocutaneous nerve, and the medial cord give off the ulnar nerve and some cutaneous nerve like medial brachial cutaneous nerve and the medial antebrachial cutaneous nerve. And the medial nerve is made of two cords. One is the lateral cord, the other is the medial cord. And for the posterior cord, it gives off the axillary nerve and the radial nerve. So when we do the scanning, because our target is a nerve, I would like to ask my students usually scan from the supraclavicular level. Because if you want to scan the bony structure, sometimes you can find that the bony structure may not, when you find that the bony structure is clear, you may find that the nerve is unclear because both structure may not run in the same plane. So because at the supraclavicular level, the brachial plexus is the most prominent. And then you can easily find on top of the fossa rib and the posterior to the subclavian artery, you can find the brachial plexus. It's like a bunch of grapes on top or posterior to the subclavian artery. And then, in this area, actually, there are many pathologies. For example, in this case, this is subclavian artery, this subclavian vein, and this is our brachial plexus. And the brachial plexus is its location is not that typical because it has been pushed away by this enlarged mass. This is the lymph node. And the lymph node, active lymph node are quite prevalent when patients have infection of the upper airway. And sometimes this enlarged lymph node would displace the brachial plexus or compress the brachial plexus and cause symptom. And then you move your transducer more cranially, you are going to reach a level, we call it interscalene level. And the interscalene level, you are going to find the nerve root is arranged in a line. So the most superficial nerve root is C5. And then if you track the nerve root to the deeper part, you are going to find C5, C6, C7, C8, and T1. So at the interscalene level, what nerve root you can see? First, the reason why we call it interscalene level is because it's interposed by two muscles. One is the anterior scalene, the other is the medial scalene. And we know both scalene muscle originate from the transverse process of our cervical vertebra. And the anterior scalene originates from the anterior tubercle of the cervical spine, and the medial scalene originates from the posterior tubercle of the cervical spine. And the nerve root is actually coursed inside the intertubercular groove. So that's why if you move your transducer distally, you can find that the nerve root the nerve root are working between two scalene muscles. So that's why we call this level interscalene level. So when we do the scanning, sometimes we may encounter some normal variant. One is the cervical rib. Cervical rib is, you can see a small bone connect to the C7 transverse process. Usually, we only have one C7 transverse process, and then there is no bone connects to it. But in patients with cervical rib, you are going to find a small bony structure connecting to C7 transverse process. And this bony structure can rub against the brachial plexus and cause nerve compressive symptoms. So this is a cervical rib. As you can see, the structure over here is the transverse process, but at the right side, you can see a triangular shaped bony structure connecting to our transverse process. This is what we call the cervical rib. So what is the ultrasound image of the cervical rib? As you can see, this is the anterior scalene, this is the middle scalene, and then you can find actually this is where the nerve root is. This is the nerve root. but the hypocoid shadow posterior to it is the cervical rib. So because your transducer is perpendicular to the bony structure, so that's why you only see a small shadow posterior to the nerve root. So this is the ultrasound image of the cervical rib. This is the cervical rib over here. So you can see the cervical rib is actually has a connection with the C7 transverse process. This is the C7 transverse process. And another structure that we usually omit during the scanning of our brachial plexus is the C8. C8 is located at the deepest part of the interscalene groove. So at the interscalene groove, you can find anterior scalene, middle scalene, and superficially you can find the superior trunk, middle trunk, and the C8 nerve root is located just on top of the pleura. And another one is the T1. So T1 is very difficult to see it, and you only see it at the very lateral part of our supraclavicular fossa. Because remember, T1, its location is actually caudal to the T1 transverse process, and we know the fossa rib connects to the T1 transverse process. So you want to see it when you see very clear image of the fossa rib. So you have to scan the brachial plexus until it reach a very lateral part. You are going to find the T1 nerve root is going to emerge from the undersurface of the fossa rib and join other brachial plexus to become the core portion of the brachial plexus. So this is how we scan the T1. So this is the fossa rib, and this is the T1 over here. So you can find I move my transducer to and the force medially and laterally. You can find there is a small bubbles emerge from the undersurface of the fossa rib. This one is the T1. So this is how we identify T1 nerve root. And what is the T1 nerve root relating to our ultrasound guided injection? Usually, if you want to perform the supraclavicular brachial plexus block, if you inject at the site too medially, you may not cover the T1 nerve root, and then you are going to find the inferior aspects of the patient is going to feel the anesthesia is not going to be successful at the middle aspect of the arm on the patient. So another thing is we have to know the reciprocal anatomy between the vertebral artery and the cervical nerve root. And the location of the cervical nerve root is actually posterior to the vertebral artery. So what is this relating to ultrasound guided injection? Remember, when we perform the ultrasound guided injection, we have to insert our needle from posterior to anterior. And the reason is if you insert from anterior to posterior, you have high chance to injure the vertebral artery. That's why we insert our needle from posterior to anterior to target the area posterior to the nerve root and anterior to the posterior tubercle of the transverse process. And then we move our transducer more cranially, you are going to reach the C7 level. And at the C7 level, a bony characteristic is you can find only one posterior tubercle, and you do not find anterior tubercle. And their structure anterior to the C7 nerve root is the vertebral artery. So if you don't turn on the power Doppler, you are going to find that the vertebral arteries actually look exactly like the C7 nerve root. So that's why before any injection over the cervical region, remember to turn on the Doppler to recognize where the artery is. And this is the cadaveric picture you can find in the paper I just shared with you. So there are several important arteries we can find in the cervical region. Common carotid artery, internal carotid artery, vertebral artery is going to originate from the subclavian artery, and it's going to pierce the foramen transversalis. And so if you turn on the Doppler, you can find the vertebral artery can be enhanced. So that's why you can prevent misrecognize the vertebral artery as the C7 nerve root. And another important thing is if you like to only use bony configuration to recognize which level you are targeting, sometimes you may encounter some normal variant, and then this normal variant can let you misrecognize the level, and then you are going to inject the wrong level. So as you can see in this case, actually we are placing our transducer at the C7 level. But you can find in this case, it has a rudimentary anterior tubercle of the C7. So this case, this is the C7 level, not the C6. And another important concept is sometimes for the beginners, they may not have the concept of whether this is the first rib or whether this is a C7 transverse process. Especially you are scanning the brachial plexus from lateral to medial. And as you can see, this is the first rib. But if you move your first rib to the middle part, you are going to find that there is a small tubercle over here. So how are you going to differentiate first rib and the C7 transverse process? You can move your transducer posteriorly, and if this is first rib, you're supposed to see a costal transverse joint. So you are going to find the T1 transverse process has an articulation with the first rib. So we know this is the first rib, not C7 transverse process. And then you move your transducer more cranially, you are going to reach the C6 level. At the C6 level, you are going to find it's a typical ultrasound, it's a typical vertebra. So you can find one anterior tubercle and the other is the posterior tubercle. And then you are going to find two nerve roots emerging from the intertubercular groove. One is the C5 nerve root, the other is the C6. And then move your transducer more cranially, you can find another transverse process. And at this level, you can find that the length of the transverse process is equal. The anterior tubercle has an equal length with the posterior tubercle. It's slightly different from the configuration of the C6 transverse process, because as you can see, this is a C6 transverse process. You can find that usually in most people, the anterior tubercle of the brachial plexus, anterior tubercle of the transverse process is longer than the posterior tubercle. But at the C5 level, you can find that the anterior tubercle has an equal length with the posterior tubercle. And also at the level, you only recognize one nerve root. This is the C5. So usually we know the C5 is going to cause inside the emerge from the part posterior to anterior scalenus muscle. But in some variant, you can find in this case, the nerve root is anterior to the anterior scalenus muscle. So when we do the injection, just like what I emphasized before, we usually insert our needle posterior to the cervical nerve root and anterior to the posterior tubercle of the transverse process, because this can prevent us from hitting the vertebral artery. So this is how we do the injection. So first we let the patient side lying and expose the lateral neck of the patient, and then we insert our needle from posterior to anterior, and then once our needle hits the perineurium of the C5, we can start to do the injection. And for the C6, we know the C6 is located deeper than C5. So the technique is relatively more difficult than injection to the C5 nerve root. And this is how we do the injection. You see, this is the posterior tubercle of the C6, and then this is the C6 nerve root. And then I let my needle duct between the C6 nerve root and the anterior to the posterior tubercle of the C6, and then you can accomplish the C6 nerve root injection safely. And when we do the injection, especially if we want to perform the interscleral block, there are several small nerves you have to be careful. One is the long thoracic nerve. We know the long thoracic nerve is the nerve emerging from the cervical, the root level of the brachial plexus. And after it emerges from the nerve root, it's going to pierce the middle splenic muscle. So in this catabolic picture, you can see this is the anterior splenic, this is the middle splenic, this is the superior trunk, and then you can find a nerve cranial to it is the dorsoscapular nerve, and then the other is this one at the bottom of the superior trunk is the suprascapular nerve, and the long thoracic nerve, you can find the nerve pierce the middle splenic, and then it's going to innervate the serratus anterior muscle. So if you keep tracking, you can find the nerve is going to course beside the lateral thoracic artery and on top of the serratus anterior muscle. And so this is how we scan the nerve at the cervical region. You can find this is the superior trunk, and the nerve emerge from the brachial plexus. And then move your transducer more distally, you can find the long thoracic nerve is actually coursing on top of the serratus anterior, and then it's the location actually I have to adjust. The suprascapular nerve is on the top, and the long thoracic nerve is at the bottom, like this. Okay, long thoracic nerve, suprascapular nerve. And then move your transducer to the infraaxial area. You are going to find that the long thoracic nerve, its location is posterior to the brachial plexus. And at the lateral trunk, you can find that the nerve is besides the lateral thoracic artery over here. So let's see how we scan the nerve in a dynamic way. So first, we put our transducer at the cervical level. Then we can find the nerve emerge from the nerve root, and then it's going to pierce the medial splenic muscle, and then it's going to course on top of the serratus anterior. So an easy way to find the nerve is if you cannot find the nerve at the level of the cervical level of the neck level, you can just go to the lateral part of the supraclavicular fossa and check the serratus anterior, and the nerve will be on top of the serratus anterior. And let's see another image. This is another thoracic, long thoracic nerve. As you can see in this case, the nerve pierces the middle splenic muscle, and then it's emerged the middle splenic muscle, and then course on top of the serratus anterior over here. And another nerve that you may encounter when you perform the injection of the cervical nerve root is the dorsoscapular nerve. And the location of the dorsoscapular nerve is cranial to the long thoracic nerve. So its location, you can see, we know the dorsoscapular nerve emerge from the C5 nerve root. So when you scan the C5 nerve root, if you find a small bubble emerge from the C5, this must be dorsoscapular nerve. And then we know the dorsoscapular nerve is going to innervate the levator scapula and the rhomboid muscle. So we can find if you track in the dorsoscapular nerve, it's going to course underneath the levator scapula. So let's watch the video. First, we place our transducer at the cervical level, and then we can find where is the dorsoscapular nerve is located over here, and then it pierces the middle scapulae muscle, and then this nerve is going to course underneath the levator scapula. You see, so we can track in the nerve to the very posterior region. And then let's talk about some pathology you may encounter when you scan a patient with upper limb pain. This is a case complaint of shoulder pain, and this case has a pre-existing history of breast cancer. As you can find, that the right side is the normal brachial plexus, so the size of the brachial plexus is quite small. But at the contralateral side, at the painful side, you can find that the nerve fascicle become extremely swollen. And the reason why the nerve fascicle becomes so swollen is because the nerve had been infiltrated by the tumor. So you can keep tracking the nerve to the cranial part. You can compare the nerve root compare the nerve root between the diseased side and the normal side. You can find the nerve root at the diseased side becomes swollen. And because this is the metastatic tumor, it usually involves the distal part of brachial plexus. So if you compare the size of the nerve root at the proximal part, you may find the nerve root seems normal. And then this is another case with metastatic brachial neuropathy. As you can see, just like what I mentioned, the nerve root becomes swollen, and you will have difficulty to identify where the epineurin is. And if you turn on a Doppler, another characteristic is you are going to find increased vascularity over the target region. And then if you use a long axis view, you are going to find in the long axis, the nerve become extremely swollen. But another presentation in patients with pre-existing malignancy is the radiation brachial neuritis. And the patient usually develops pain or discomfort 5 or 10 years after previous history of the radiation. As you can see, I placed my transducer at the root level. Actually, you cannot see anything because all the muscle become fibrotic. So this is the nerve root. And usually at this level, we need to see anterior scalenus and the middle scalenus muscle. But in this case, we cannot see anything because all the muscle become atrophic. And the nerve, the epineurin and the perineurin cannot be differentiated. And this is another case suffering from the radiation brachial neuritis. As you can see, this is a nerve root, and the nerve root become very swollen because of being entrapped by the fibrotic band of the muscle. So you can see this is anterior scalenus, it's atrophic and fibrotic. And this is another part. You can find the anterior scalenus. You do not see many normal muscle parts. If you are familiar with zonal anatomy of the muscle, you should know normal muscle should have an anechoic or hypoechoic background with some hyperechoic septum or hyperechoic perimyxin. But in this case, you only see fibrotic tissue, and the nerve root becomes swollen. So if you track the nerve to the trunk level, you are going to find the fascicle inside the nerve root cannot be seen clearly. All the nerve fascicle merge together. And then this is another case. We use long axis view to see the nerve root. You can find the nerve root is adhesive together. And then you cannot find where is C5, where the C6 is. And then this is, the other part. You can find this part is relatively normal. You can still find a part of the anterior sclerae, and this is the nerve root. So in patients with early radiation-induced neuritis, you can try to use hydrodissection to relieve the entrapment from those fibrotic bands. For example, this case has breast cancer, and then he received radiation, and then 5 years later, she started to find that she had difficulty to raise the shoulder. So in order to prevent the fibrosis keep getting worse, we use hydrodissection to relieve the adhesion every 2 weeks. And for patients with brachial plexus injury, we know the nerve injury, if you evaluate the severity by using Sedan classification, we know there are different grades of severity. The most mild type is the neuroplasia. That means only the myelin sheath is damaged. But for the indoneurin, perineurin, they are relatively intact. But in some severe cases, you may find some of them has avulsion from the root level or rupture at the peripheral nerve, and in some cases, they are going to develop neuroma. So this is a case with brachial plexus injury, and we are scanning the nerve at actually cranial to the part of injury. So you can find that the patient has already developed a neuroma. And then distal to the neuroma, you cannot find anything. You only see the scar and some tethered brachial plexus. But for patients with brachial plexus injury, sometimes a direct visualizing of the nerve is difficult because most of nerve has been encircled by the fibrotic tissue. So that's why a very important thing is you have to evaluate the integrity of the muscle it innervates. For example, in this case, we can find the infraspinatus become atrophic and the deltoid muscle is relatively normal. So we are going to know the patient may have the damage at the level, for example, close to the branch of the suprascapular nerve. And another common scenario we may encounter in patients with upper extremity is the thoracic outlet syndrome. And the thoracic outlet syndrome can be caused by direct nerve compression or caused by vascular insufficiency. And the vascular type is more prevalent than the neuronal type. So in this case, you can find the patient complain of numbness when he tried to raise the arm, and it's also related to the respiration. And then we can find that during expiration, the artery is relatively patent, and the structure on top of it is the brachial plexus. And once we let the patient inspirate, because of increased intrathoracic pressure, so the subclavian band is collapsed, and then the patient start to have symptoms. And when we use the MR angiography, surprisingly, we do not see any narrowing of the subclavian artery. So in this case, it also reflects the advantage of using ultrasound to evaluation of a patient with thoracic outlet syndrome. Because using ultrasound, we can dynamically evaluate when the symptom happens. And if you use MR image, probably you cannot do that in such real time. And another structure that we may encounter in patients with neck pain is the superficial cervical plexus problem. And it's coursing between the anterior sclerae and the sternocleidomastoid muscle. And then you can see some small bubbles interposed between two muscles. And then if you want to do the injection, you can insert your needle from posterior to anterior to target the area between the sternocleidomastoid muscle and the anterior sclerae muscles. And the recent last year we had an article published. It's related to a case. Actually, the case is myself complaint of neck pain after upper airway infection. So I remember at that time I had difficulty to rotate my neck. So what happened to my neck? This is ultrasound image. This is anterior scalenus, this is middle scalenus. Normally, we should not see any hyperechoic structure between two muscles. But here we can find, this is the greater auricular nerve, This is the swollen lymph node. So this swollen lymph nodes actually compress the nerve and cause symptom. So in this case, this is how we scan those small nerve over the neck. So we can find that the greater auricular nerve, its location is on top of the sternocleidomastoid muscle. So if you move your transducer cranially and caudally, you are going to see the nerve is going to wrap around the superior sternocleidomastoid muscle. So that's why you can do the ultrasound guided injection. So your target will be the gap between the sternocleidomastoid muscle and the anterior scalenus. This is your target. And then you can use a linear transducer and then insert your needle in this plane. And then once your needle insert into the target, you can start to push the injector. Another nerve is the suprascapular nerve. We know the suprascapular nerve emerges from the superior trunk of the brachial plexus. And there are many ways to scan it. But if you want to scan the suprascapular nerve at the very proximal portion, you can find it emerge from the superior trunk of the brachial plexus, and it's usually located posterior to it. And then you can see the nerve emerge from the brachial plexus, and it's located underneath the muscle. This is omohyoid muscle. So once you recognize the nerve, you can do the injection like this way. This is a nerve. And the nerve may be compressed if you, carry a heavy backpack, because the strength of the backpack can easily compress the nerve and cause symptom. And in some cases, we are going to perform the ultrasound guided proximal suprascapular nerve block. And this is our paper. We use this technique to treat patients with recalcitrant shoulder pain, because for these cases, they may have difficulty to sit upright to receive the standardized suprascapular nerve block. So in this case, we let the patients be supine, and then we perform the proximal suprascapular nerve block. And if you want to use the size of suprascapular nerve to diagnose neuropathy, it's very important to know the normal value of the nerve. And for the nerve, if you scan from the proximal portion, its size is smaller than you scan it at the distal part. Because at the distal part, you are going to find the nerve is going to divide it into many branches. So if you include all the branches together, it's going to increase the overall cross-sectional area of the nerve. So if you are interested in how the distribution is regarding the normal suprascapular nerve from the neck to its distal insertion, you are welcome to download this article. And in patients with, there is a syndrome we call it Parsonage-Turner syndrome. It's idiopathic brachial neuritis. And in this case, the suprascapular nerve is usually involved. So we can see at the left side is the normal side. You can find that the suprascapular nerve is very small. But at the painful side, you can find the suprascapular nerve is swollen. And the patient also develops supraspinatus muscle and the infraspinatus muscle atrophy. And lastly, I'm going to emphasize when you do the scanning, it's very important to not misrecognize some vascular structure from the nerve root. There are two important arteries we have to pay attention. One is the transverse cervical artery. The other is the suprascapular artery. Both arteries are the branch of the subclavian artery, but the transverse cervical artery it originates from the more middle and the more deep part, and for the suprascapular artery, it's going to course more laterally, and then innervate the supraspinatus muscle through on top of the transverse suprascapular ligament. So if you put out transducer at the level of the supraclavicular brachial plexus, you are going to find this is superior trunk, middle trunk, inferior trunk. And then there are two arteries. This is a subclavian artery, and the transverse cervical artery sometimes is going to pierce the brachial plexus and the course to the posterior part, and then it will become the dorsoscapular artery. And then the other on top of it is a subclavian, suprascapular artery. It's going to circle the top of the superior trunk. And then if you move your transducer to the posterior part, you are going to the suprascapular artery. It's going to beside the suprascapular nerve. Okay. Today, I'm glad to share my experience regarding how to scan the cervical spine, and also provide some clinical parallel of the scanning of the brachial plexus. And this is the picture we have taken last year. You can see Desi over here. And then there are many good friends from Indonesia. And then this is the picture we have taken last March with Dr. Yusak, Dr. Moni, and many good friends. So I hope one day the pandemic will disappear, and then we can meet in person. And if you are interested in my talk, you can refer to MSK Ultrasound Club. There are so many useful information in this club in Facebook. Thank you very much.